O'Keen, and we are two brown chicks changing the face of therapy on
Both sides of the couch.
Yes.
Today, we are excited to have Dr. Meagan Houston.
Yes.
In an unfortunately timely topic. We're going to talk about suicide and self-harm. And as most of you probably have heard, Spade died of suicide yesterday? Yesterday morning. Yesterday morning. And so we've had this plan for like a month, but it just so happens I feel like this is going to be a good conversation to have, especially as that news has just come out yesterday.
I know. So that was the first thing I thought was, wow, so glad to have you on this week to be able to talk about this, which, I mean, so difficult to talk about, I think, sometimes, but we need to have these conversations.
Yeah,
absolutely.
Right. Before, we should have talked about this ahead of time. We always do. We have a couple things going on. One, should we give the results now? I know we're not supposed to make it.
We're not supposed to. Tune in Saturday and they'll find out. We want to update y'all.
I feel like we should just do it. Like, look, we not like advertising it. Look, we didn't follow the rules the first time. I'm gonna follow them this time. Anyway, we'll update you guys on the contest coming up soon. But we're also, this month is National Pride Month.
Yes.
And so this is why we're wearing Pride shirts. Proud Ally, and just my little Pride heart.
Yes.
These are for sale. We are in partnership with the Queer Center, who most of you know is Justin.
Justin Smith, we see you
Justin.
watching.
Is Justin on that?
Yeah, he's there.
And so we are partnering with Justin and the Queer Center to bring these shirts for you, and you get a discounted rate if you use the coupon code PRIDE, all capital letters. Was it all capital letters?
Yes.
All capital letters, PRIDE, at shop.Melanin and Mental Health. So go get your shirts, show people that you are a proud ally, that you support LGBTQ plus communities.
Have some proud therapist shirts on there.
Proud
also.
therapist, proud queer, just proud. And mugs. I did add a couple mugs on
those
there.
were cute. Yeah, there's so much cute stuff on there right now, and it really is. You know, we've talked about this before. Of we can't really have the discussion of mental health in our communities without being inclusive and also really taking into consideration, which you do a lot of work around with, also kind of the additional stressors that the LGBTQ community has.
Absolutely. So many other risk factors that put them at an increased risk for suicide. So yes, any chance I get to use my platform to promote that awareness, I do it.
Yes.
Because it's so critical.
Yeah.
Especially for our youth.
Absolutely.
So because they go through a lot.
Yeah.
You know, and I remember being 12, 13, 14, 15 and feeling like time lasted forever, right? Like, oh my God, why am I still 13?
12 seems to like go on for like at least 10 years.
Right.
Want to be a teenager.
Right. Why? I want to be 18 someday.
Yes. Get me out this house.
Exactly. And so for them, it seems like it goes on forever.
Yeah.
And they do have a hard time making sense of everything and dealing with the pain and the rejection.
Right.
So it is. It's such a huge issue.
Right.
And it's definitely something I hold near and dear because it's devastating to see what that can do.
Right.
And then they're more likely also to be victims of violence.
Absolutely.
Also.
Yeah.
So much going on. So
Yeah.
I'm so glad that you're here. I mean, this could not have been at a better time. So I'm excited about everything we're going to dive into.
All right. So we're going to start the conversation with just some understandings of what self-harm versus suicide, because I think that there's some confusion even amongst mental health professionals, but especially amongst the lay community of understanding that how self-harm and suicide are related and or not related. So how do you define self-harm?
The way I define self-harm is the deliberate and intentional destruction of flesh.
Okay.
So it is when you are intentionally causing yourself pain in order to feel better, right? So it's not just about the destruction of the flesh, but it's about the intentionality behind it.
Okay.
Like it is for a purpose.
Okay.
And it's usually to relieve something, to feel better, to regulate your emotions, and unfortunately it works. It does work.
And I'm so glad you added that part, because I think that's the part that people often miss, that it's to feel better.
Right.
And I think that confuses people sometimes. Like, how do you feel better by hurting yourself? Can you tell us a little bit about how that works?
Absolutely. Well, there's several theories as to why that works for some people. There is an addiction model. Okay, about cutting. Because what happens is when you cut, you release opioids into your system, you release oxytocin, you release dopamine, you release all of these neurotransmitters, right, and chemicals, and they do make you feel good. They make you feel better.
Yeah.
There was an interesting study done in 2010 by a researcher named Prosson, who was looking at the interaction between monkeys, right? Most great research is found by mistake, right? So he was looking at monkeys, and he noticed that some monkeys were very difficult to soothe, right? They didn't get along with the other monkeys. They were really bad. Even when the mothers would groom them and clean them, they still had difficulty regulating themselves. So they were like, what's happening with these monkeys, right? So they looked at their brains, did MRIs, CAT scans, all this good stuff, and they found that these monkeys had lower levels of endogenous opioid receptors in their brain. And so they started wondering, I wonder if this is what's happening for people that have borderline personality disorder. Is this why they have difficulty regulating? Is this why they choose to self-harm? Because we know people with that particular disorder, right, do harm themselves. They cut themselves. It's not to get high, but to feel better.
Well, and even the conflict part that you're kind of talking about.
Oh, yeah, the difficulty with relationships and getting along, and the inability to self-regulate.
Wow.
Right? It's either black or white, right? The gray, they don't really tolerate gray. They don't do a whole lot of emotion regulation.
Right.
And so when they did look at individuals that were diagnosed with borderline personality disorder and did the same kind of studies, they found that, in fact, they did have lower levels of endogenous opioid receptors, which is why they think that they engage in those cutting and self-harm behaviors, which is why they choose to use opiates. That's their drug of choice. It's going to be painkillers and prescription. And it's not to get high, it's to feel better. It's to feel normal.
Just to get regulated.
Just to get regulated. Exactly.
Wow.
So there's several reasons and mechanisms as to why it works. Some theorists believe that it's because you get a chance to avoid what you feel inside. So instead of feeling that psychic pain, you feel what's out here, that physical pain, and so you avoid it.
So your focus kind of goes to the physical, and you don't have to be going to the to that more non-tangible or intangible.
Right, exactly. And some people feel like, it's just for tension reduction. Like there's this buildup and you feel overwhelmed, and when you cut yourself, it's like a release for some people.
Wow.
So there's several different reasons why, but all of them indicate that it works. And it's why it's so difficult to extinguish and so difficult to work with.
Right.
Yeah, because then what is the what is the alternative?
Exactly.
Right.
Exactly.
Well, and I like the way that you describe it, because I think kind of sometimes the conversations lack compassion for the person that maybe does engage in this behavior, and so to just understand, like, they're trying to just feel better.
That's right. That's it. It's unhealthy, but they're trying to feel better.
Right.
Yes.
Yeah. Right.
Yes.
Thank you for explaining that. That helps me to kind of understand it a bit more also.
Right. So I have a question when you said about the intentional part, because I do feel like there are things that people do that can seem like it can fall under self-harm, but I guess it's not, like picking. Or things that are kind of like mindless that still cause harm to the skin.
Right. Well, that's more impulsive, right? So like trichotillomania, those things. Right. They can be looked at as self-harm, but then it's still the same kind of mechanism, right? When you feel this built-up anxiety and tension, and when you pick, it goes away.
Okay.
So you're still doing it to your detriment. You still are destroying your flesh, so it does fall under it. But there's different kinds of self-harm behaviors. There's pathological NSSI, which is non-suicidal self-injury. There is this piece, the compulsive NSSI is what you're talking about, right? Compulsive non-suicidal self-injury, which is that trichotillomania, which is that picking. Yes. And then you have the NSSI that we typically see, which is kind of that doing it for the self-regulation piece, period, right? It starts at 12 to 14. It's a learned behavior. It's not coming from impulses or because you're having a psychotic episode and you're trying to remove a digit or get something out of your body because you're psychotic. It is literally, you've learned that this works for you. You have been exposed to this and you've learned that it works. And there's stages to cutting behaviors. So I know that a big issue that came up a few weeks ago was about Willow Smith. Right? And her mom looked shocked. Right, when we heard about what was happening with her. And so it doesn't surprise me that she didn't know, because there are stages to cutting and self-harm behavior. You have an experimentation stage where you're kind of checking it out, right? You learn about it, you may cut yourself. Like, I've had some kids cut themselves and they're like, this is not for me. You know,
right.
like this is not like
Ooh,
I didn't like it. It's hurt.
Yeah.
Right.
I didn't like
I'm
it.
good.
Yeah.
Right. No.
Right.
Why do
Right.
people do this?
Right.
Right.
Mhm.
So that's the experimentation stage. But then there's an exploration stage where they are cutting, but it's controlled. Right? It's controlled. It's almost like drug addiction.
Right.
So they cut, they know where to cut.
Exactly.
They're very strategic with it. They may be engaging with other people who cut. They may be on social media groups, learning how to be better cutters, seeking out information.
Wow.
And then there's the encapsulation stage where this is what they do. It is their primary method of coping. And so this is the stage that we typically get them.
Okay.
Because now it's out of control.
Now people know.
Now
see
people
it.
know, they see it, they're sloppy with how they do it, they get urges. This is where the urges come in to cut.
Okay.
Because it takes about 12 to 15 times to cut is what research has shown before it becomes addictive. And you start having that urge to do it, and your body actually wants that.
Wow.
Right?
Okay.
To regulate itself.
I think bringing up Willow Smith, I was surprised and not surprised by the reactions of other people, where as opposed to like it being like a honest moment and her sharing like, yes, I went through this, but you know, she was in the early stages, it sounds like, and so she was able to kind of get herself together and decide this isn't what's good for me. It turned into like one, a criticism of her the parents,
Right.
and two, I knew she was weird. This is proof that she was.
Right.
And
Wow.
I have my own opinion, but I was just so shocked by the response and the lack of knowledge or information when it comes to those behaviors, where it turned into like a parent, like their parents suck, why wouldn't they know? They should have known.
them.
Yeah.
Right.
And so I don't know, I found that interesting. So I'm glad the way you explained it, where it's these stages and people, there are a lot of kids that have tried it and just haven't went further, and you may never know.
You may never know.
Right.
Exactly.
That doesn't mean you're not a aware parent or, you know, because if my kid is cutting herself, which I've had clients that cut themselves in their inner thigh, why would I ever ask them, let me see your inner thigh?
Right.
Or even think to that. And I think it's difficult, you know, you can't monitor them like all day long, you know, like they go to school, you know, like you do your best. But that parent shaming, why do you think it is so difficult for people to have compassion for people who engage in self-harming behavior?
Because they don't understand it. It's like, why would it make sense for you why would you cut yourself to feel better? Like, that doesn't even make sense. Like, I harm myself to feel better, and if you don't understand it, you judge it.
Right.
You know? And it happens all the time.
Yeah.
And the teenagers that I've worked with have been African American, have been Hispanic, have been Asian, have been white, that have engaged. Like, this transcends culture in that way. And all these parents had different roles. Some were more active than others, but all of them still did not know. And they're shocked, right? But their kids aren't just exposed to them. They're exposed to other people and other children. And now we've got the internet, right? Social media is a gift and a curse.
But when you said that there's groups.
Oh, yes.
Wow.
Oh, yeah, there's pro-injury groups and websites that you can go to.
Instagram has, they've blocked a lot of them, or like certain hashtags you can't go to, but there are pages and hashtags specifically so you can go and look at people cutting and tell their stories and things like that.
Absolutely.
And not just like in a healing way. You know, like, this is how I cut myself, so people don't know. Exactly.
Absolutely.
Exactly.
And even YouTube, right? YouTube's been around since 2006. It
Yeah.
feels longer, right? But it's only 2006. And there's about 5,000 plus videos dedicated to self-harm behaviors and going on. My nephew uses YouTube to learn how to do his math. You know, and now parents, and so parents aren't aware that these things exist or that these pro-injury sites exist. Even some mental health professionals, we're not. I've done many seminars where people are like, I'm shocked by this. I did not know this was out there. You know, what is happening? Is this legal? You know, why are people able to do this? And it's freedom of speech. You know, when one comes down, another goes up. Yes. And all kinds of sites might have it. Like, for instance, what is it? Not necessarily Instagram, but Tumblr. Right? Tumblr seems pretty harmless, right? You can go to Tumblr and learn how to make a, you know, you can make a hat and learn how to knit on Tumblr, right? But you can also go on there and learn how to cut and learn how to hide.
The only thing I know about Tumblr is like porn stuff. I didn't even know you can learn how to knit a hat. All the people I know that have Tumblrs is so they can follow certain.
You can learn anything on the internet.
I knew Pinterest, but Tumblr I did not know that was teachable.
Tumblr's got all kinds of groups you can go on. And WikiHow, right? WikiHow, you can go on WikiHow and learn things. But WikiHow also has pages dedicated to how to be emo in middle school or how to hide your self-injury.
Wow, I would have never. That's what I would have never.
Right, Wiki Hell.
Mm-hmm. Wow. Mm-hmm. Okay.
So there's so many, and parents really aren't aware.
Right.
And I think even when you are aware, it's difficult to how do you manage I mean, you can do so much, and then, you know, I've said this before, and then they'll go to school. And even the schools, you know, my kids who, you know, when they were in elementary, the schools will have, you know, protection against it, but somehow the kids know how to hack it.
Oh yeah.
You know, like they'll tell me, we were in class and this one kid managed to hack it and was watching, you know, like whatever, or playing a game, and I'm like, so, but this is why these conversations are so important.
Exactly. And you have to talk about them, because some people are like, well, if I say something to my kid, will it pique their interest? I'm like, well, it will pique their interest if you don't. You know, you have to, you know, kind of acclimate them to that. Like, these things are out there. This is what it's about. It's unhealthy. If you feel like you're going through something, come talk to me. But they need to know that it exists, or there's an intrigue that's there when they sneak around and do it.
And if you're not talking about it, it's just like, if you're not talking to them about sex, somebody is. You know? Somebody is. It's a click away. No matter how much you want to avoid the certain conversations, we just can't.
You brought up the diversity within your clients that self-harm. But it seems that a lot of times minorities feel like that's not our issue for whatever reason.
We do.
So what can you say about, like, is this something new within our communities, or is it just something that we just weren't aware of because it felt so distant from us?
I think it's not necessarily new. I think, again, it's about exposure. You know, I think that we aren't really aware because of stereotypes and stigma. Like, oh, well, that's you know, we don't do that. Just like, you know, people of color don't, you know, complete suicide. We don't. That's white folk stuff, or whatever it is, whatever stereotype you have, and that's not true. And so we're not looking for those things, and we are just shocked and taken aback, or it's because the kid is weird, right? Like Willow Smith, it's weird, it's the parents' fault. But I'm like, no, it is still about exposure. These things are out there for our children to see, and they're not just in our households. They're out here with other people. They're exposed to other things on a regular basis. As you know, as far as cutting goes and self-harm behaviors, it really became popular in the 90s, right? 90s, 2000s, because there is a culture, emo culture, right? It's the emo standing for emotional. Where emo culture was the first subculture to be on the internet in the 90s that promoted those unhealthy behaviors. And now I understand that there are certain genres of emo. It's like mild to severe, where you might just dabble in the clothing or dabble in the music. But historically, and you know, it originated from self-loathing, self-hate, promoting those unhealthy behaviors, self-harm behaviors, and encouraging it within the group. And so now you have somebody out here that may not belong, that may be bullied or ostracized. They can come to this group and get accepted and loved.
And feel what we all want to feel, which is connection.
Exactly. Exactly. And so with the internet, these things spread like wildfire. You know, so it's not that it's new, it's about the exposure.
It's just, you can access it in a way that you couldn't before.
Absolutely. And when I ask my clients about the origin of theirs, just like, well, I heard about it, or I had a friend that did. You know, and these are kids
that just popped into their head.
Exactly. And these are kids that might be on a, you know, they come from different kinds of groups, and it just doesn't affect one kind of kid at all. No, absolutely. And to believe that, you're going to miss something. If you believe that.
Sometimes they're the things we want to believe, right? We've got so much other stuff to think about. Like, let's be exempt from that. But you know,
but we're not. And even as far as suicide, you know, there was a study that was completed in 2015 that shows that African American children between the ages of 5 and 11, their suicide rates have doubled. From 1993 to 2012. That's unheard of. That it's doubled. You know, it was the 9th leading cause of death for African American children between 2008 and 2012. So something is happening. Something is changing. So I mean, it is there.
I read a recent one about Latina teens girls also being at high risk.
Absolutely, absolutely. Latina females, white females in general, but Latina females, their suicide rates have increased, almost tripled in the last 10 years.
Wow.
And we don't know what is happening in the community.
Yeah, what's happening to our children?
Exactly.
Yeah.
Exactly. What is happening? Again, is it exposure? Is it learning? Is it the trauma that you're dealing with? Is it, increased risk factors in your community? Is there trauma or depression or anxiety that's going untreated?
Right. Well, and I think nowadays, we've talked about this before, it's like when we were young, when I was young, I could go home and then just close the door and be away from it. And kids nowadays, they can't be away from it. They're on the social media, they're being inundated with these images also. What you should be like, what you shouldn't be like, and then just all of the images of the trauma, all the violence that they're seeing.
Absolutely, on a regular basis.
Without us necessarily having maybe the connections that we had before as a family to balance that out.
Yeah.
And so you kind of think about, just as adults, how difficult it is for us to process some of this, and we have adult coping skills.
Right.
What's it like? And like you said earlier, just being 12. I remember being 12. Ugh. That was hard.
Exactly.
Just dealing with family stuff, and now all this other stuff that you're trying to process in the world, and also form your own identity. Oh,
it's overwhelming.
Right.
And like you said, what's happening and changing, that you don't have those family bonds, and you're not having these conversations, and they're trying to figure things out on their own.
Yeah. So when we talk about suicide versus self-harm, I know that some people, when the first sign of cutting or anything like that, you're suicidal, send you to a psych hospital.
Right.
What's the difference, I guess, between, how do you know if somebody's just performing self-harm versus suicidal?
Intentionality. With somebody who is self-harming, and again, research is now calling it non-suicidal self-injury, NSSI, because you're not doing it to die.
Right.
You're doing it to feel better. Somebody who is suicidal is doing it to cease, to exist, right? They don't want to be here, they don't want to deal, whereas the other person is trying to cope. So there's a big difference. However, it's related in that people who engage in NSSI behaviors, their suicide rate does increase.
Okay.
But it's for different reasons. It's for reasons of habituation. You become desensitized. I mean, you might cut deeper the next time. You might need more, so that's going to expose you. Also, a common attitude towards suicide is ambivalence. You're ambivalent. You don't really know what you want to do. Do I want to die? And when you're cutting, you remove that ambivalence. Every time you harm yourself, you're taking that ambivalence away. So that's another reason why it increases your risk.
Okay.
Because of that exposure.
Okay.
Okay.
I think that's important, what you said about just, like you said earlier, intention, because when working with clients that have performed self-harm, or if it's been like a cut and they end up, I know I've done assessments to see if someone is suicidal, if they need to go to a psych hospital, those type of things. And one of the questions is, well, why? Like, what led to it? What outcome were you hoping for? And so sometimes they'll say, well, I don't know. I mean, I didn't want to die, but I don't know. So it's not necessarily it helps me cope, or it feels good, or whatever the case may be.
Right.
So that means it sounds like that means they could still be suicidal, because the intention was not relief or a coping of some sort.
It could be. That's hard when you've got, especially when they can't articulate what's happening for them, which is where we come in and being well versus and ask, well, did you do it to feel better? Did you do it because you were in a bad place? Have you done this before? But we have to know the questions, the right questions to ask to give them that language. Because sometimes, I've worked with children who will go to school and say, oh, I just want to, I'm just going to bash myself in the head with a hammer, and teachers are freaking out. When really he's saying, I'm overwhelmed. And he doesn't have the language or the emotional vocabulary to express what's happening.
Well, and I think you make a good point, especially when you're a professional, be it a teacher or, I remember fresh out of grad school, you're kind of trying to figure some of this out, and you don't know what questions to ask, and it is so alarming. And especially everything that we keep hearing, it's like, so I love that you're giving us the language on, okay, if you're seeing these things, these are some things that you can ask.
Absolutely.
Because it is incredibly frightening.
Oh,
right.
absolutely. Because you don't know, again, the intentionality behind it.
Exactly.
And you assume, we are going to go there like, who does this? Unless you're trying to do, harm yourself, right? Take your life, or this is significant, and it's very uncomfortable to deal with, especially when we're talking about children, right? Because we've got parents. We want to make sure we keep children alive. We do this work because we care.
Right.
Absolutely.
Right. And so we are invested in the outcome, and you want to make sure you do a really good job.
Yes. Yes.
So for those professionals, for the parents, what should you be looking for when it comes to suicidal ideations?
Ooh. It's a good question. It seems like a simple question, but it's really not.
Right.
Because, unfortunately, if somebody wants to take their life, they're going to do it. We can only be as preventive as they allow us to be.
Right.
So there are certain things you can look for, but it's just so, like I said, that's a hard question.
Right.
Certain signs that you can look for is if your child is, I look at extreme changes or drastic changes in behavior, for one. So if I have a child that's typically pretty melancholy, or they're just kind of like, Eeyore-like, right? They're like, oh God, life is awful, but thanks for noticing, that kind of deal. And then all of a sudden they're happy, they're excited, they're really gung-ho about life. Now they're in therapy with me. Do I want to think it's because I'm great at my job?
Yes, of course.
So right.
But
we
in real life,
our clients don't make major changes
Not that
like
big,
that,
yeah.
right? It's little baby steps that they take. So I want to know what's happening. Have you come to some resolve about taking your life? Are you now in a good place because you know how to fix it? Like what's going on? So any drastic changes in behavior in either direction. If you have a child that's pretty outgoing and all of a sudden they're withdrawn, they're isolated, they don't have any interest, they're locking themselves in their room, they're becoming really private, you need to ask questions. It's not because they're going through puberty and they're going through it and you want to give them their space. No, we need to say, hey, what's going on? I'm noticing that something is different. Listening to how they talk, if there's some hopelessness there, or helplessness, or they're having difficulties at school with friends and relationships, because relationships are big at that age. And if there's relationship difficulty, that's a red flag. To me, that's a red flag. Because again, that's their world, that's their bubble. And if something's going wrong in their bubble, they take that to heart. And I think as adults, we sometimes forget.
How difficult it is.
And so we minimize it, like, oh, it's just a phase, it'll be okay. But no, we really need to be paying attention.
Especially when they're experiencing a lot of firsts. Because as adults, we are jaded to certain things, and it's like, oh, it's not that big of a deal, or that's just because you're young. But yes, it's because they're young, and so they haven't experienced these emotions before, and so how do we help them cope with it?
Exactly, and guide them through that. A first, like you said, heartbreak, a first relationship, even, being oosted out your friend group, right? You're kicked out of your friend group, and explaining that to them. So, because I've had a client that was referred to me because she was addicted to her Instagram or her phone, right? Every time it would ding, chime, light up, she's anxious, she can't sleep, she can't eat, and it's because she was kicked out of her friend group. And they would lie to her, like, no, we're not going to the party, and then she look on Instagram, they're at the party.
That's so hard.
And for her, that was devastating.
Yes, of course. Because at that age, I think that's the thing that we forget as adults. Like, your job is to be social. That's what you do. You're learning about your relationships and you in relation to others.
Oh, exactly.
That's why it's so difficult, because you're not really sure what's going on physically, emotionally. And, again, we're wired for connection, and to be cut off by that connection, that is, or it's just, their whole world gets flipped up.
Exactly. It's devastating. And it has long-lasting effects, right?
Absolutely.
I remember back in my day, watching like Ricky Lake, and Sally Jesse Raphael, or Montel Williams, and they would have Donahue, right? And they would have those shows like I'm 30 and Fabulous, right? Look at me now. And as a kid, I'm looking at like, why do you care? Like, why does it matter? But knowing what I know now, I'm like, wow, they were really traumatized. When they were younger, like, this is a part where you're learning about your identity and who you are, and sometimes things get stuck. right? And you don't outgrow that, or it stays with you, and it affects your self-esteem and your self-image in certain ways. And I know it doesn't happen for everybody, but it doesn't mean it doesn't happen for some people.
Absolutely.
Right? And we have to be sensitive to that and aware of that.
Yes. Absolutely.
So we asked you to bring a resource.
You did.
And you brought a wonderful resource.
Yes.
So can you explain a little bit about that?
I brought my workbook.
Yes. Show them
her workbook.
Treating suicidal clients and self-harm behaviors. And I developed this workbook on my seminar that I've done for a few years. And I based my seminar on the things that I didn't get. You know, as a graduate student, as a mental health professional, there's certain questions I had and that nobody really could answer for me. And there were certain trainings that I wanted to have that I really couldn't find or get. So I developed it based on that. So this is a really awesome resource that has information about certain groups and special populations, because certain DSM-5 diagnoses have a higher risk for suicide. So delineating what those are, talking about the risk for veterans or the elderly, LGBTQ, adolescents, they all come with their own special set of risks, and we need to be aware of that. And so this book has that. It has information about assessments and what to look for, how to assess thoroughly for suicide risk, because everybody doesn't have like a template or a model they use, and some people don't understand that there's a difference between doing something like a Columbia assessment where you're kind of getting numbers and looking at that versus a suicide risk assessment. Like there is a difference between doing a screener versus an assessment, and kind of delineating that and putting all of that in here. And there's information here about long-term care, short-term care, how to work with self-harm, the origins of self-harm, crisis intervention information, self-care.
Yes, please.
Self-care, because this impacts us too, right? As mental health
Please.
professionals. So this is a hard work, right? And a lot of times we give, but we're not doing anything to put back into ourselves. And so there's a lot of information here about that. So it literally, to me, covers suicide and self-harm A to Z. Anything that you could possibly want to know is going to be in this.
Look, I love that.
It's super awesome. It took me a few years to do. I don't know if I'll do it again. I wasn't expecting that part. But it was worth it.
How nice. I wish I would have had that when I was coming out of grad school, because that was one of my biggest fears when you're in internship, like, oh my goodness, what do I do? What should I know? And then you're so uncertain, and you're so vulnerable as a new, therapist. That having something like that would have been so helpful to at least
give you some confidence.
And what to do and where to start. Instead of just wing it. Well, just talk them through it.
There's like, no harm contracts.
Exactly. And even in this workbook, to me it's more up to date. It's more 21st century. So there's information here about apps and how to use apps for your clients, and how social media plays a role in suicide and self-harm behaviors and teletherapy, and the comfort and the guidance on doing teletherapy with suicidal clients, because all of that is relevant.
You can have to write another book now.
Right.
You can have to.
Right.
I dropped the link in the video so that if y'all are interested, y'all can go ahead and get it, and I'll also put it in the show notes for the people that are listening on the podcast. It seems like a dope resource, and we appreciate it.
Thank you. I'm excited. This is for you guys.
Thank you so much.
You're welcome.
This is so dope. I am so excited about this.
Well,
we're going to keep it in our library in here.
Yes.
Yay,
good. So
hopefully it's helpful. Like, it's just, you have it with you.
Right.
To be able to pull out and, work with your clients. Whatever it is you need to do, if you need to just consult with each other, it's there.
Awesome. Thank you. So tell us a little bit about what you do as a psychologist in your, I guess, is that considered agency work and then private practice?
Yes.
Yeah.
And we were talking a little bit beforehand, like, you have just
a history.
Wow. But okay, let the people know.
Right. You want me to start from where I was to now, or you want me just to talk about like where I am now and then what I did before?
You can start from beginning, like what led to you getting to where you are now.
Okay. Well, my first job right out of graduate school was as a correctional psychologist, a prison psychologist. And I worked at the Federal Correctional Complex in Beaumont, Texas, and I was there for 6 years. At Beaumont, we had 4 institutions. So there's a camp a low, a medium, and a penitentiary. Okay, a penitentiary. So these are all security levels of the prison. I was one of 2 psychologists for about 2,000 or so inmates in a medium security institution.
One of 2 for 2,000?
Yes. There were staff psychologists. There's other psychologists, but they're supervisory psychologists. So, yeah, there was 2 of us for the medium to make sure that we handled whatever mental health needs the inmates had at that particular location.
Wow.
But if we had to go to the penitentiary or the low or the camp, wherever we had to go, we would do that as well. So it was a very interesting job, a lot of crisis management. I tell people all the time, I ask them, have you ever worked with somebody with borderline personality disorder or antisocial or narcissistic personality disorder? So imagine somebody with maybe one of those main pieces and then traits of another, and dealing with that all day. So a lot of behavioral management, a lot of crisis management. My job there basically was to make sure that the institution ran orderly, though. Like, there was some commitment to rehabilitation, but not really. You know, it was more management. And I went there because I'm like, you know, there's a lot of people of color in there. There's a lot of men of color. Let me go in here and help. And I really care about it. I want to save the world. Yes. I want to save it. And it wasn't that way. Like, I did. It was, it was a little different. You know, I love the job. I enjoyed it. You know, it's where I got my start, even with dealing with suicidal clients and self-harm, because there's a lot of that. A lot of self-harm. Oh, yeah. And acting out in that setting. So learning how to manage that and deal with that there gave me a foundation, you know, where to start. So I did that for 6 years, and I've maintained a private practice for about 8 years. So I did that while I was in the federal correctional setting. But in that setting too, let me go back really fast. We had different roles as well. Like we worked with staff there. I was a mental health expert on the hostage negotiation team there, so it was interesting. I was the suicide. There's a program they have called the Inmate Companion Program, where we teach inmates how to watch other suicidal inmates. And it's cost effective, but it's a really good program because you pick your top-notch inmates. So you pick the best of the best to be in this particular program. So training them on suicide and what to look for and how to work with somebody who was suicide was a really interesting experience. So yeah, so we got a lot of wonderful experiences in that setting. It was just high risk, go every day, crisis management every day. And plus I lived in Humble, I worked in Beaumont.
Oh my goodness!
So I made that commute.
Wow!
For 6 years. Absolutely. Right.
What was that drive home like?
Well, you know, actually it wasn't bad because I got a chance to decompress.
Yeah, I was gonna say, kind of okay.
And get it out of my, you know, get it out, process my day. I had somebody I would carpool with, so it made it a lot better.
Good.
In that setting. But while I was there, I also had a private practice. Now, in my private practice, I work with various agencies. I have contracts. I see private clients. I work with veterans there, Social Security disability clients. I work as a substance abuse professional, so providing assessments, almost like fit for duty evaluations for people who are employed with the Department of Transportation. So if they fail a drug test or anything like that, they have to come see me. I determine whether or not they have a substance use disorder, and then a course of treatment.
Wow.
And then say whether or not.
Work.
Yeah, it's interesting. It's interesting work, and then I maintain private clients.
Wow.
So, like right now, I'm on therapy for black girls, which is awesome. Therapy for black girls rocks. I love it. I love the clients that I'm getting from there. It's just, it's an amazing resource. And I also present across the country for PESI. So I teach for PESI. So
I
busy. I do. I don't do it as much as I used to, but I do. When I go, I'm in 3 cities for 3 days. Once a month or once every 2 or 3 or 4 months, whatever I can do, because I'm so busy with everything else that's going on. So I've done that since about 2012, 13. So for a little while now, and I absolutely love it.
Yeah,
which is where I got the idea. Yeah, PESI's good. It's an awesome company. I love being able to instruct and use that platform to help educate other mental health professionals on all the issues that we're talking about today. It's just an amazing thing to do, to go across the country and do that, and to be able to have the opportunity to help somebody. It's really interesting. So I do that in my private practice, and now currently I am also a police psychologist for the
That's so cool.
For the Houston Police Department.
Right.
So I'm there. That's my 40-hour-a-week job. So I'm there 4 days a week, and there I provide. Well, there's 7 of us, and we provide psychological services to the police officers and their family members. So we provide individual therapy, couples therapy, premarital therapy, marital therapy. We provide psychological assessments for their children. So if they have ADHD or another learning disability, we'll do the assessments for that. And provide any documentation to the school. We teach at the police academy. We consult with the chief of police or whoever needs us. And now we're responding on scene. So if an officer is involved in a shooting, we will respond on scene to deal with whatever is happening on that scene to help kind of manage the scene and provide any treatment that they need for us to do for that officer and be there to support them. What else? We also see them if they're involved in a shooting. They have 72 hours to come see us, so we do that. We're also responsible for screening the recruits that come through there. So we're like the gatekeepers. So if you do not pass psychological services, the career, being a police officer in Houston is going to be slim to none, because they're really big on their mental health. And making sure that their officers are mentally ready. We know that if there is a use of force situation, that typically it's because an officer's personal life is spilling over into their work life. And if the personal life is managed well, then the work life is going to be managed well, right? And it's such a unique job in that it's systemic. It's a trickle down. So if an officer is having a good day and they're in a good space, then so is a citizen, right? So it's an amazing job. I absolutely love it. I love it. I love having a chance to work with the officers, work with their family members. It's one of the most rewarding jobs I've ever had.
Fantastic.
So it's awesome.
Wow. I don't know when you're resting. When are you doing your self-care?
I do. I stay here. Right. I get it in.
Good.
Right. Like I'm married. My husband's awesome. I have 2 dogs. I travel. Like I'm everywhere. So, but I'm busy. I like variety though. I think I would get bored
if you had to do
if I had to do the same thing every single day. You know, even in a prison setting, like I could never have a schedule. Like I never knew what would be popping, what I would need to do, run where, do whatever. So it was an interesting job there.
Very cool.
Very cool. Okay, so what makes you a dope therapist?
What makes me a dope therapist? I think my genuineness, you know, makes me a dope therapist. Like my relatability. Like I'm very relatable, and when we're in that room together, like I'm not Dr. Houston and you are the client. Like we're 2 people in that room working, you know, and you have to be real and you have to be genuine. Your clients have to feel that you're in there with it. In there with it with them, right? Like we are going to get through
collaboration
and collaborate together, and you can't be in there with airs or, you know, all stale and stiff. Well, how do you feel about that? Like I don't think you can do that, right? Like, you have to use yourself in the room. And as therapists, we are the tool in the room. We're all we have in there, and so I think that is what makes me a dope therapist. Like I'm just really real. My clients, like whatever comes out of my mouth is not really filtered. My clients know that, right? That's a good thing. It's appropriate. But I mean, that's what they know what to expect, and they know what to expect. And I feel like if I do what everybody else does outside of the room and sugarcoat and pussyfoot around the issue, then I'm not giving you anything different. So in this room, we're real. We're naked, we're unashamed, and we're going to take care of what we need to take care of.
So
I think that's
vulnerability.
Vulnerability, and you have to be genuine to get that.
Absolutely.
With your clients.
So why is therapy dope?
Why is therapy not dope?
I mean, if you didn't hear all of that,
everything about therapy is dope. I think therapy is dope because it's transformational. Right? Like it changes lives. It changes where you are. It changes who you are, and you grow. And to be in that room with somebody in their pain and to see them through that to the other side. There's nothing like it, you know, and you can't not know. Like once you know, you have options, right? When they come to us, maybe that, you know, ignorance is bliss. I don't know anything, but once you come see us and come see me in that room, you do know, and now it's your choice whether or not you do something different. And if you let me help you with that choice, it's a beautiful thing, you know. So everything about therapy is amazing.
Oh, I love it. I love your enthusiasm.
Yes.
I love it.
So one of the questions is like, what are you doing to change the face of therapy? But I feel like you just named 50 things that you're doing
to change the world.
To change everything. More specifically, actually, you have an event coming up on Friday with HAMFT.
I do.
And that is a training on
LGBTQ youth and suicide, assessment, loss, and support. So not only are we going to be talking about LGBTQ youth in the community and how the factors and all of the issues that come with being, because it's not because you're LGBTQIA or P that puts you at a high risk for suicide. It's everything that comes with it.
Right.
It's all these outside influences that you have to deal with every single day and make you question who you are.
Right.
And, you know, so we're going to talk about that and, you know, suicide prevention. And then we're also going to be talking about working with survivors of suicide. You know, working with the family members that are left over and how to cope and deal with that and how we take care of ourselves. Because we lose clients too, right? And sometimes we ignore that. And sometimes mental health professionals, we develop post-traumatic stress or whatever else, and we've got to deal with that. So we'll be talking about all of that on Friday. So I'm super excited about it.
Awesome.
Yes.
Awesome.
Okay, and then the last thing is just how do people get in contact with you? How do they follow you on social media? You know, you just recently got on social media.
Yes.
You
proud of me, dog, but why you laughing? You laughing hard.
That's so good, though. That is amazing. That you see the value of social media.
I do. I see the value. I have a friend, Patrice Douglas. She's awesome.
Yes, we had her on.
Yeah, which is awesome. Patrice, I met Patrice in Phoenix at a suicide training there, and she was like, "You need to,
you need to know
get your life right. Get your life. What are you doing, right?" So I am on social media. You can follow me on Instagram at Dr Meagan N on Instagram. I also have a LinkedIn, Dr Meagan in Houston, and a Facebook, Dr Meagan in Houston on Facebook.
Yes.
As well.
Yes.
But I am loving the Instagram though, because it's a really good platform for information.
Yes.
Right?
Absolutely.
And for networking.
Yes.
Right? Like that's how I met you guys.
Yes, that's right.
So
Started following you.
it's
I remember
awesome.
I saw you post, I think, in one of the Facebook groups about your book, and I was like, she's from Houston. We need to meet this woman. Who is she? Let me start following her.
Right.
And then we just met her at the Patrice Douglas.
Yeah, we got to
Right.
meet you in person
Yeah.
there.
Right.
Yeah.
Yes, at her launch.
At her launch.
So, and that worked out beautifully, and here I am.
Here
And
you
so,
are.
But I'm loving this. Like, what you guys are doing is epic.
Thank you.
You know, and bringing awareness to the community and to just everybody, whoever's watching this. Like,
Right.
it's amazing.
Yes,
Yeah, we
thank
appreciate
you.
you for coming on.
Thank
We're going to need to get you on Melanin and Mental Health Directory, too.
I'll do it.
Right.
I'm on it. I'm on
Let
it.
the people know where you're at.
Right, I'm on it. I'm on it. I'm on it.
Yes.
Absolutely.
Love it.
Yes.
All right. I think that's all. Do we have any?
What do we have? So
Always
we
something.
covered the shirts. We have a webinar. We're going to have all the details later.
LGBT clients.
Yes, that's later this month. Technically, we can't update you yet.
But I think you are. I'm sorry, I'm making me kind of nervous. I'm sorry.
I just feel like we'll wait until the official announcement rolls eyes. Anyway, so we have Justin will be presenting later on this month. I think he might be posting about it.
Right,
I see him popping up.
Yes. He did for the shirts and then for the HMFT training for this Friday.
Yeah, and then June 21st. What's that Thursday?
What's the date, Justin?
June 21st.
Yes.
I believe at 7 p.m. Justin will be presenting about working with clients, LGBTQ clients.
Yes.
So we're going to do a webinar and we'll be posting about that very, very soon so you guys can sign up. I think that's pretty much it.
Yep.
So thank you guys for joining us again. We hope you enjoyed it and we'll see y'all next time.
Bye.